Hello, NephU community. My name is Dr. Kevin Charlton. I'm a Senior Medical Science Liaison with Otsuka, and I work in the nephrology group. In this podcast, I'd like to give you a brief overview of the role of hyponatremia in the development of falls and fractures. This program is paid for by Otsuka Pharmaceutical Development and Commercialization, Inc., and I am an employee of Otsuka Pharmaceutical Development and Commercialization, Inc. Now, fractures, particularly hip fractures, are known to pose a serious health risk in the elderly. This is because they're associated with such a high level of morbidity and mortality. Clinical data shows that over 13% of patients who actually suffer a hip fracture die within the first 6 months, and this figure rises to 24% of that patient population within 1 year of the fracture occurring. Now, in terms of those who survive beyond 6 months, only 25 to 50% actually recover their ability to conduct their daily activities. So there are real concerns in this patient population about the loss of independence and the need for social support to recover from this condition. Now, the FRAX, or Fracture Risk Assessment tool, is an index of risk factors which is used to predict the likelihood of a fracture occurring. Now, some of the factors included in this index are included there, but clearly this is not a list that is complete at this point in time. For example, there's a great deal of evidence to support the contention that chronic hyponatremia is an independent risk factor for the development of fractures. Now, hyponatremia is defined as a serum sodium less than 135 milliequivalents per liter. It's not only the most common electrolyte disorder that you see in the hospital setting, it's also the most common electrolyte disorder you see in the community and in institutions such as nursing homes. Now, virtually all hyponatremia is dilutional in nature. So you see it in conditions that are associated with an excess of body water, such as heart failure, SIADH, and cirrhosis. Mild to moderate chronic hyponatremia, that's serum sodium levels between 125 and 135 milliequivalents per liter, was considered to be asymptomatic, but it's become increasingly obvious that it's implicated as a risk factor not only for falls and fractures, but also for osteoporosis and neurocognitive disabilities, especially in the elderly patient population. We also know that less severe ranges of serum sodium in the 135 to 130 milliequivalents per liter is also associated with cognitive deficits and falls. Chronic hyponatremia appears to contribute to bone fractures by two separate mechanisms. Firstly, on the left, it produces mild cognitive impairment. This leads to an unsteady gait, confusion, lethargy, affects the balance of patients, and this obviously leads to an increased risk for falls. Now, in the mechanism on the right, it incorporates osteoporosis. Now, about 30% of the body's stores of sodium are incorporated into bone tissue, and this acts as a reservoir during periods of hyponatremia. So in this particular mechanism, you actually see an increase in osteoclast activity, which leads to increased resorption of bone, decreased bone mineralization, and this leads to decreased tensile strength of the bones and hence fragile bones. Now, taken together, an increased risk of falls allied with fragile bones increases the risk for bone fractures. I hope you found this brief overview of the role of hyponatremia in the development of falls and fractures useful. If you'd like further information on this topic or more in-depth presentations, then please access www.nephu.org for further information. Thank you for your attention.